want to thank everyone for attending Marilee's office hours. And I am pleased to be sharing my office hours. I'm going to introduce Michael here in a minute, but our topic today is can't live with them, can't live without them. Our friend, the HL7v2 message. They're still playing a very important role in information exchange or healthcare data exchange, and we're going to talk about why. And for those of you who've not attended one of my sessions before, first of all, we'd love to see your lovely smiling face. So if you could turn your camera on, we would love that. And we really encourage everyone to join in the conversation. I will try to stop and pause. But also feel free to, if you want to get our attention, put something in the chat. And I've got Erica who will be monitoring the chat and is free to interrupt me so that I can stop and we can have more back and forth conversation, because that's really what this is all about. So let me just real quickly, for those of you who are new with us, introduce our Zen. So we're Zen Healthcare IT. We're an interoperability platform company. We help make direct integrations much easier through our Gemini integration hub. And we're also certified gateways to the national networks, the trust frameworks like Care Equality and TUFCA, and we're certified on Commonwealth and eHealth Exchange. So our customers, do a combination of those things. And we definitely keep this conversation focused on the topic at hand. But I will say that the office hours this week is sponsored by our JSON to HL7v2 Smart Transformation Service for our customers many of them are modern health tech vendors. Our JSON to HL7v2 service offers a much easier way of handling HL7v2 connections when they're trying to scale across multiple provider groups and hospitals and health systems. So with that, let's dive into introducing our guests, Michael. Michael is a dear friend of mine. We have worked together on the Care Quality Advisory Council. He is, and Michael, please correct me if the title is not current, Director of Digital Applications.
Yeah. Yeah, it's a very generic. There's about 30 of us here at Sutter with various and sundry responsibilities, but it's the HR homogenization. How do you say that? Homogenization of kind of the title. So we all fit into a certain HR frame. So that's the official title. But like Mike in Oregon, I'm interface interoperability guy as well. So I've been doing this a while with lots of different forums and forays, as you see there, including stints with HIMSS and other organizations. The laundry list is too long. And like Mike earlier mentioned, probably need to update my LinkedIn profile. There's probably some stuff I'm not doing anymore that I need to deactivate, but not, I like to read stuff on LinkedIn. I don't tend to update my stuff, other than I do have a cool new image there. So,
Oh, now we have to all go check that out. Well, Michael brings both a winning personality, but certainly a just amazing amount of subject matter expertise. And the work that you're doing, Michael, on an ongoing basis as co-chair of the Care Advisory Council, participating in the Epic Care Everywhere Governing Council, and also being on the Health Exchange board, really helps bring that a very big umbrella perspective, as well as, being right there in a hospital doing, or certainly having lots of conversations about how innovative health tech vendors integrate with your Epic system there at Sutter is very helpful perspective for this call. So I appreciate you joining us again.
Yeah, glad to be here. And just because all the high end internet, national interoperability stuff is on the board, I've probably got a V2 interface that I wrote at Hoag Hospital in 1996 using CAI interface engine that's probably still running. So I've got lots of chops in the V2 world, and I appreciate the conversation and invite. And I also argue with vendors who say that they do FHIR APIs and act like HL7v2 is something separate. I'm like, it's all HL7 standard. So I'm a little persnickety in that space as well. But Glad to be here.
That is a really good point. It's the reason why we just didn't call this HL7. It is HL7v2 specifically, not that we won't talk about FHIR and other things, but I agree with you 100%, Michael. People often miss that nuance that lots of data standards fall under the HL7 umbrella for sure. So I am sure many of you on this call are aware that FHIR is hot. It's the hot topic. And I know the ASTP would love everyone to be on FHIR tomorrow or yesterday, probably is a better way of saying it. But the reality is HL7v2 messaging is often a better way of doing data exchange depending upon the use case. And we're going to talk about this kind of idea of using the right tool for the job. But, why is HL7v2 often where we need to kind of land when we're doing direct integrations with hospitals and health systems and provider groups or, EMRs? Well, first of all, it's a very mature data standard. I actually looked this up in 1989, fall of 1989 was when the first official HL7v2 specification was published. So yes, it goes way back, and I figured that had to be around that date because Gemini's first company in healthcare was a practice management system. And we started doing that right in also that same time, 1989, 1990. And we were dealing with some of the first lab interfaces ever in the country. And those, of course, were HL7v2. So it's been around for a very long time. One of the other reasons why it is a very useful data standard to use is that it is designed to be a push model. So it's very event and workflow driven. And as Michael said to me this week, it's a great use case for I need to know when something changes, like someone gets booked on the appointment scheduler that wasn't there yesterday, or a new visit occurred, or a new patient has been registered. You don't have to come get that data. It will push that data to you. And the other big one is these HL7v2 messages are bidirectional. And we'll talk a little bit about the differences. Different EMRs support different HL7v2 workflows, but especially in the larger EMRs, the ones that have been around the longest, it is not unusual for almost every one of those message types that we'll talk about to be bidirectional. So we can call out a use case, but you can also usually just turn it around and it will work the other direction also. Because it's been around for a long time, because it is event and workflow driven, it is tightly embedded in EHR and practice management system workflows, and especially those that obviously have been around for a long time, which is often the ones that are bigger, have the biggest footprint that most health tech vendors are running into when they're out there, selling their technology, or if you're a health information exchange, when you're doing onboarding of your participants to your health information exchange. And one of the big ones too is currently it's almost always the only way to get data into the EMR. So there's a couple of ways of doing that, but this comes up a lot when we're talking with prospects where they need to push a result, for example, or push some updated patient demographic data because they're, kind of a medical front door type application. We'll talk a little bit about those APIs often being read only. Michael, anything else that you want to add here in terms of, where you see HL7v2 as just having a bit of an advantage that I didn't already cover?
Yeah, I mean, I think that part of this is it's industrial strength. You know who you're connecting with. So most of those run across a site to site if it's an external app or an internal network. You're on a port and IP, so you've got a very specific connection. So there's not a security concern or risk there. And I think that it's been since 1989. So there are trillions and billions, and I don't know. I can't get past trillion. I don't know what the gazillion is. That a made up term? I'm not sure, but there have been gazillions of these transactions that go out, and even in the FHIR world, to Marilee's point, is we don't want applications coming in and querying and looking for new data. So a lot of the integration patterns I've seen actually rely on the ADT or scheduling message to actually trigger additional data. So you don't have to create a large payload in V2 to actually put that data out. It actually kind of starts the engagement with that external application that might want to leverage FHIR APIs. to say, hey, there's new information, you might want to come back and get it depending on that outbound event. And so it's a cornerstone to the kind of a integration pattern that I've seen a lot with even the new technologies that allow for the leveraging of V2 as well as FHIR so that people can feel hot or cool and new, or whatever you want to think about the vendors who want to do FHIR but don't know it's an HL7 standard, but think it's the right thing to say. Maybe they could say blockchain too, and then they can kind of take advantage of that. But anyway, so no, but just industrial, everybody's using it. It's a certified standard. It's continued to be supported and updated. If you were to actually look, it's V2.x is what I always say, because I don't know whether we're on 5, 6, 7, 8, 9, 10, whatever. So it's not a dead standard. They're continuing to look at and improve it as we add new data elements or new data elements of importance that need to be included in existing transaction sets. So.
Yeah, exactly. And I threw up just a couple of examples here where, when we're talking with our prospects, these are common use cases. The patient is registered into the EHR, and then a patient demographic data is pushed out. That might be to the HIE. And Mike, this would be maybe a good place to talk about it from your perspective as a technical resource in the health information exchange. Can you maybe describe the kind of HL7 messages that you guys are working with on a regular basis?
Yeah, we regularly get ADT messages. So those are the demographic updates that we get to help keep all of our network up to date on patients' name changes, all that stuff. We also get ORUs. So those are the structured results. Sometimes they're transcribed documents as well, which often fall under MDMs, but we get both. Those are the three types we get. We've also explored getting SIUs a little bit, but usually the ADTs are a little bit more meaty for us, and they serve our population better than this patient has an upcoming appointment or something like that. So ADTs, ORUs, MDMs, those are what we primarily deal in.
Awesome. And I think the orders and results for a lot of health tech vendors can be something that you can do a lot of creative things with. Oftentimes if there's an innovative piece of digital health tech that the provider group or the hospital or health system is using, a lot of times it fits that. Maybe you're not a lab or doing radiology, but you're doing some sort of additional service on behalf of the patient, which can be an order, and whatever you're doing, whatever your outcome is, can be pushed back in as a result. And Mike, I know Michael, you've talked a little bit about kind of the configurability specifically in Epic around the results coming back. Can you maybe talk about that a little bit?
I mean, I think that, when you look at the message types, you've got the ORU, which is traditionally kind of observation results. So typically your lab, and then you have the MDM, which tends to be transcription or more of a larger narrative. And I think that as you look at the types of applications that are creating and generating results, at least on the EHR side, the typical ORU is landing in a flow sheet. So a view where the data is discretely segmented and actually populating particular fields, and it's used on the back end for clinical decision support, and for essentially trending and other sorts of reporting and mechanisms inside the EHR versus the narrative around the transcribe report. So if you think old school dictation, you've got the doc, he calls on the phone, he says, okay, I did X, Y, and Z, and then the transcription office sends that back as a singular document. And you see a lot of that kind of narrative responses in some of those MDM documents. I think, from a configurability standpoint, it creates a non-discrete data. So there's less of the ability to apply rules and routing to that narrative. But I think that inside the EHR, they're doing more and more. And again, I think I win something for mentioning AI first. I don't know what that is, but leveraging the AI tools across that narrative to help actually pull out discrete information and then actually repopulate into fields inside the EHR, things that we're starting to see with the Gen AI, a huge adoption in the Gen AI space with some of those technologies that allows the clinician to talk to the patient, the ambient AI to listen to that inside that encounter, and then put that report back in. And layering on top of that, the ability to pull out discrete things like orders or pharmacy, for lab or pharmacy or imaging. And then that narrative turns into an HL7v2 order. So it populates workflow, and then that data goes to the right spots leveraging the internal tools to drive those messaging. So those are sorts of things that I'm seeing either happening today or plan to happen inside of the EHRs that are really kind of moving us forward to continue to leverage these standards while also having implemented new technologies, because the backbone's there, it works. And again, it's that old saying, don't fix what's not broken or don't break what's fixed, or whichever way you want to go with that. I'm going to go with both ways that works. So.
Awesome. And I saw Holly. Holly, so glad that you joined us. And Holly's commenting about 360X and HL7. Holly, do you mind commenting on that?
What I wrote is probably about all I know. Michael may be able to answer more. But I know we use HL7v2 messages that are automated if a patient no-shows and is in the 360X process or cancels the appointment.
Yeah. And to Mike's point, they would be an the SIU. I want to say 16, but I always get my numbers mixed up. But an SIU S16. But basically, what happens on the 360X is and Holly is the expert in this space related to closed loop referrals, leveraging direct, as well as leveraging HL7 to keep the status updated on both sides. So what happens today is a referral gets sent to a particular organization. Scheduling or whatever occurs on that side, or to Holly's example, the patient was scheduled but then no shows. Information goes back to create visibility on the sending system or the referring provider so that they know the current status of that. So it leverages existing standards and interoperability frameworks to allow for that closed loop, not creating anything net new, right? It's leveraging everything that currently exists. So direct messaging exists, V2 messaging exists. But building on a new use case to maximize visibility between organizations, eliminate phone calls or emails or those other non-automated ways to kind of get that information today, and it reduces that administrative burden. So.
And Holly and Michael, you bring up a very important point, and I think we've got a note to talk about this further along here, is that oftentimes we talk about these things, as specific subject matters, but I do think it's a very important point that, you don't have to use just one thing. And it is not unusual at all for the solution to be a combination of direct secure messaging, HL7v2 message, in this use case, we're triggering a hit to the FHIR API because we got an ADT message. We have the patient demographic data. Now we know who to go ask for. Or we could layer in, for example, an ADT feed to go ask for data from the national network because we need to, kind of pre-fetch clinical data in anticipation of an appointment. So we could do it off an SIU message, for example. So it is actually really fun how all of these different data standards can work together, which is why it's really important to, not have just a one method approach, ideally, in order to have, kind of best optimized results.
Hey, Marilee, just go back to that for one quick
sure.
second. I would tell you that an underutilized of the message standards is that master file updates. And part of the reason I say that, especially in the lab world, is compendiums get updated on a regular basis. And what happens if you have an order and or result that lands in a spot that doesn't currently have a dictionary entry that allows the file against, is it errors, and then it turns into work for somebody to do. So if you haven't used that interface type before, it allows you to synchronize those dictionaries. A lot of times you have a singular a source of truth for provider information, and then that feeds into different systems. So that allows you for your EHR, if your credentialing system is the source of truth for your internal providers, you would be able to send master file notifications from that credentialing system to your EHR in order to keep that provider directory inside the EHR up to date. Same thing for order and result compendiums for different types of integrations, lab or imaging, are regularly the ones that I'm familiar with. But if you haven't done that before and you have a manual process where people send emails to distribution lists saying, hey, we've changed something, room and beds, there's lots of things that change on a regular basis, new locations. If there's a source of truth for that information, leveraging these MFN interface types will help with that synchronization without any extra effort. Once that information's changed in the source, it rolls downhill to those systems that need that information, as opposed to what happens in a lot of organizations is that gets manually managed and probably more often than not missed with some of those updates. So if you haven't used those before, it would be something to take a look at to help with that, again, that administrative burden. So
that's a really good point, Michael. It feels like we were talking about those more back in the days that the early days of connecting practice management and EMRs together, where those were often different systems. And they, we've kind of gotten away from thinking about those. So that's an excellent point. So sometimes the question we'll get was, well, Marilee, you're kind of talking like all EHRs or practice management systems support HL7v2. And I want to say I'm asking for people to challenge me on this, by the way. My opinion is yes, for legacy EHRs that have been around a while. So almost all your acute care, Epic, Cerner's, Meditechs of the world, and your legacy ambulatory softwares like eClinicalWorks, NextGen, Athena Health. It's interesting because Athena Health has kind of always led the charge on API-driven connectivity, but I did a quick double check just to make sure I wasn't lying. And there's, took me 2 seconds to find Athena Health's, specifications for HL7v2.
We've got one going live today on Athena V2 message feed.
Well,
so
and I was
they are
going
alive
to
and well.
Yeah, I was going to say, Mike, y'all probably have our HIE friends have probably have more experience than anyone in kind of knowing the predominance. How often do you run into an EMR that doesn't have the ability to send you an ADT feed, at least?
We've only had a couple of them that have said we have an API and that's what you're stuck with, but 99%, they have it available whether or not the fees to set up such a feed are cost
we're going to talk
prohibitive.
about that.
It's a whole different ball of wax, but they have the capability.
Yeah, we're going to talk about that problem.
And some of the other things that you'd look at, like in the healthcare ecosystem, we've done a significant outreach to social determinants of health, so social agencies in the community. How do they get data? Or your EMS, do they use a standard called NEMSIS? How do you translate NEMSIS into the HL7 world to share identities for ambulance crews dropping off patients at your ED? So there's definitely spaces in the healthcare ecosystem that may traditionally not have used HL7 as the standard, but I think that for the folks that are running an ambulatory clinic or a hospital, they're going to run into systems that do HL7. It's really when you get to that secondary, skilled nursing facilities, dental offices, whatever, using non-certified technology. That's where at least my experience in finding folks that aren't familiar with or technology that's not using the V2 methodology for that. So.
Yeah, excellent point. I've kind of been focused in this conversation because so many of our prospects are trying to connect to a hospital EMR or an ambulatory practice group. But it's a very good point. If you are that provider and you're trying to exchange data with your community or your health information exchange, yes, when you get out into the folks, the EMS and the long-term cares, the home health, yes, that now you start getting into even highly specialized kind of data, and NEMSIS being a great example of that, because we have some customers that are EMS agencies for sure. But I think just in terms of being, a really good low-hanging fruit, which is kind of what we're talking about here. And Mike, it's very good to hear that in your experience, the vast majority of practices that you're trying to connect to, at least, their EMRs do support that. But, my experience is that I think people kind of thought that people were going to stop creating new electronic health record systems. Well, that's not true. We're still seeing new players come into the marketplace. And some of those folks are kind of settling on FHIR or a proprietary API. So that's where you might run into an issue. And then Mike, you just said that you're even getting data via CSV from some of your dental practices.
But it maps to V2s. We made it work, and then integrates with our system.
The question is what can you not map to V2? That I would need
Yeah.
that example.
Yeah, as long as you
Because
have the,
Marilee will talk about taking JSON and turning it into V2 soon. So we got
Yes.
XML to V2, we got CSVs. Yeah, I think
yeah,
we've all done some variant using, internal mapping technology to get data in the right space, whether table or whatever, to be pipe delimited ASCII with interesting control characters and repeating.
which is why modern health tech vendors are going, please don't make me work with that. And we can fix
If
that
any of you
problem.
out there have had to try to count HL7 fields with those stupid pipes and manually kind of figure out whether it's field 3 or 4, you'll know a headache, an ice cream headache when you find that particular one. So
Nice
there's plenty of
remake.
good tools out there that do that parsing for you. But yeah, that early days, that was how I figured out whether it was MSH 4 or 5. So
Yeah. Yeah, for sure. And to piggyback on that, Zen's JSON to HL7v2 service, which is bidirectional and supports all HL7v2 message types, is designed for the the newer health tech vendors to not have to worry about it, but still be able to support it and not have to, have that interface just built from scratch every time you go to the next. So it's just handed a JSON model and you get a standard HL7v2 to the spec. And then all we have to worry about, or our customers, is just that little bit of a localization reconciling between, different variations of HL7v2, which makes it a lot easier. Moving on to kind of thinking about it from the FHIR perspective. So I'll quickly go through these and Michael, ask you to weigh in. FHIR today is mostly a pull model or a query model, kind of the same model that we see in National Exchange for things like Care Quality and TEFCA. And so it's really kind of tough to do that if you don't know who the patient is in the first place, right? So that creates a problem. And to Michael's point, that's where combining an ADT feed and then using that to give you the information so you can now go ask for data from the FHIR API to pull the more, clinical related data, for example, is useful. Otherwise, you have to just randomly hit the FHIR API, what we call polling. Polling's not good. Polling creates a lot of issues for everybody, so we don't recommend doing that. And even though there's this concept in the FHIR standard of FHIR subscriptions, where you should be able to subscribe to something and have it be more of at least notify you. I'm laughing at the jokes in the chat. Those are not widely used and they're kind of limited in terms of their options. And so this is why this, FHIR isn't solving all problems today. We mentioned it's almost all read only. Why is that? Well, because in the original promoting interoperability or EHR certification requirements, the FHIR requirement was really built around this concept of consumer access, related to the Cures Act. And so they didn't require that the FHIR APIs be bidirectional. And so the EMRs, most of which are not FHIR native or really have the easy ability to support FHIR, it's expensive for them to retool their legacy systems to support FHIR. So they're just doing what they have to do, what the ASTP is telling them they have to do. And even though it's been around since 2011, which is mind-boggling, it is still, that's a 22-year gap between when HL7 came out and FHIR came out. So, you can kind of see that even though it's been around a while, it's still significantly less mature as a data standard than HL7v2. So I'll pass it back over to you, Michael. Anything I missed there?
Yeah, I mean, I think the big thing is so if you were in in a lot of different places, people don't think that there's a proliferation of FHIR out in use in the marketplace, but there actually is. But it's all inside the frame of your individual organization. I think the last time that I was looking at the reports here at Sutter, we had over 400 million resource calls in a particular month. That means there are APIs that are running in applications and connecting to our EHR and actually hitting resources for various and sundry different datas and business purposes and application uses and those sorts of things. So the thing is, it's inside the frame of and the security of our organization. And I think what people are looking for and what we're talking about from a V2 or even just a national standpoint is having that happen outside the frame of your organization, be able to exchange data, whether that's via IAS with your, personal health app or your Apple Health Kit on your phone or whatever that might be. And that's really where the directory and security and authorization process really is going to play in. There's a discussion about a national directory. I know Amy Gleason had talked about that in the last couple of meetings that I've been in, around creating a central directory that includes the endpoint, that includes how do you secure, how do you access, where do you go for information from this particular organization. I think that's been really the having a trusted source to know what's the address? So where do I need to go to get data from this organization? And then what's the security around that? How do I enroll so that they're going to allow me to come in and get data from their system as a trusted source? And I think that's what's been happening on the national networks. eHealth Exchange, Commonwealth, and Care Quality and TEFCA have a directory of endpoints, and they're the ones kind of directing traffic, the air traffic controller of our national networks. The next layer of that is adding in those endpoints and the security around having that so that you can actually exchange data between organizations with FHIR. And I think that's probably the big leap forward that we really need from a national standpoint to see FHIR at scale across organizations. I think the other piece is I think some implementations of bulk FHIR have not gone as well as folks would have liked to do some of the other kind of business use cases. So there's some places there where you're doing a lot of polling because you can't get bulk FHIR to work in a useful way and a meaningful way for a particular business process. So I think there's some gaps in that capability now, which is why V2 continues to be the standard. Same thing with just pub. Again, I use pub sub, publish, subscribe. But the public subscribe model is I can publish my FHIR data somewhere, but how do I authorize subscribers? And if there's a variance in and let's just pretend we're creating an ADT feed, but it's a FHIR ADT feed. So just using that as kind of the example, who should I allow subscribe to that ADT feed? And then what data should they have access to? In California, behavioral health data, maternal data, gender identity data. There are some data that's protected in that protected class. And there may be some subscribers that can get that data and some subscribers that shouldn't get that data. How do I control that? In the V2 world, I just basically have a point-to-point connection and I filter that data on those fields and manage that through my middleware, through my vendor to make sure that the right data gets to the right spot. In a pub sub model, I'm publishing this FHIR feed of patient demographic data, and I have different subscribers, and then how do you control that, right? So there's some gaps in the capabilities in FHIR today, or at least in my current understanding of what's available in the marketplace. And having somebody like Zen or somebody in the middle that can help manage that would be something that you need to have in place, because today, at least as I understand it in our implementation, there's no real ability to filter resource data out of an API. So if you give somebody access to the meds resource in Epic, you're going to get every med that's there, regardless of whether it's a protected or a scheduled medication. It's the med resource. So there's no real control at the resource level in your technologies, in the certified technologies. Again, my experience has been mostly Epic over my 30 years. My first install of Epic was in 98 at Palo Alto. So anyway, so those are the sorts of things that I look at, Marilee. I think are items for development.
Very interesting point about the kind of one-to-many that exists when you're with the FHIR world, where you're doing a query. But yes, to your point, well, how do you differentiate who gets what? Jim, I think I saw your hand go up. No? Okay, you were stretching. All right, that was great stuff. The other thing I wanted to comment on is what data is available via FHIR or other APIs, and so this is where USCDI comes into play. And for years, for a very, very long time, I didn't look up the date. We've been stuck on version 1, which is fairly limited in terms of the scope of the data. The ASTP has a V3, USCDI V3 requirement, but they delayed enforcement through March 1st. And I don't know if anyone has any news on whether that's gotten moved again or not. On the positive side, ASTP would love to go faster. If you go from like 1 to 3 to 6 or 5, 6, 7, or 6, that the recommended the new data elements coming in have been very limited. And what ASTP now wants to do is go, no, we need to make a big leap. We need to have appointment data available in USCDI, for example. And so, we don't know the timing, but there is a draft of the V7 out there that has a lot of new potential data getting added to the US EDI data standard. Of course, we don't know how long that's going to take. What we'd really like to do right now is two things. One, get enforcement on V3. And secondly, get TUFCA to do a requirement, because right now TUFCA's requirement is US EDI V1, and we really need them to align with the ASTP and get to the V3. Michael, you have any insights on that?
I don't, but I would always, there's actually an HL7, a V3 HL7 standard that SureScripts uses. So you might want to preface V3 with USCDI V3.
Yeah, USCDI V3.
Yeah.
Thank you.
Because when you talk V3, I have nightmares of the use cases. I had a wall full of HL7 V3 use cases that my brain, I think, exploded trying to figure out V3, and there wasn't wide adoption of HL7 V3 in the States. I think that more in Europe, but no, I think the big thing, as you look at where the ASTP direction is, they're really moving forward full throttle into the FHIR world. I think that we just need to kind of continue to provide feedback on where there's gaps. One of the gaps in the new versions or some of the drafts are kind of removing old certification requirements because they believe that the market, the marketplace will drive the need for that. I'll pick one as direct. I know if you're unaware, direct was removed as a requirement for certification moving forward. They moved to more certifying APIs. And so when you have new entrants to the marketplace and they see, oh, well, I don't have to support direct, I'm building this AI-based EHR. If you think about direct, it does a lot of things to include supporting 360X, which Holly mentioned in the chat. So you really need to be careful of. It's great to move forward, but you can't unplug the existing standards to create something new or a new way. Or if you go back, why are railroad tracks a certain width, or why are fire hydrants? They all have the same thing. Like, what was the evolution of that standard, and what thing broke when it didn't work? The wives tale is that railroad tracks are a certain width is because it was the width of a donkey or horse's ass. I mean, whether that's true or not, I don't know, but that's how they came upon that standard. And then when they tried to bring the railroads together, the tracks, because they didn't have a standard, they couldn't connect them when they got to Chicago or St. Louis or wherever in the middle of the country, right? So as we do these things and evolve these standards, we can't disconnect the old to build the new without consideration of how those things kind of merge together in the future, and what do you lose by disconnecting or not including that moving forward. So
yeah, absolutely. And so the lesson here is there are a lot of options. There's a lot of change happening, but what do you do now? And the lesson is really, well, you need to use the best tool for the job. And I think that's where people that have expertise across different standards and different use cases can really add value. For those of you who maybe have less experience, we have a lot of people on this call, by the way, that have a ton of experience. So, I just want to acknowledge that, but we always have some folks that are exploring these things for the first time. So I also want to talk about the downside, and Michael mentioned one of them, or someone did, maybe it was Mike. And that is that the EHRs, one of the downsides is the HL7v2 are often sold those interfaces with license fees or service fees to do an implementation. So that's something that I know we always coach our customers on to kind of prepare for that, or prepare for a conversation. I think, sometimes those licenses are sold in bulk, and there might be some extra HL7 licenses sitting around that maybe could be used for high priority projects. So it isn't always a blocker, but it certainly can be. The other one is, as Michael said, VPNs are often used, which, is great. It is certainly secure. However, because network engineers now get involved, it can really slow things down. And I'm going to talk here in a minute about, you can do HL7v2 without necessarily having to have the security model of a VPN. And I'd love to see us moving, to other options because of the timing involved with getting VPN set up. Of course, because it's been around a long time, you do have a lot of different HL7v2 versions. Talked to a prospect yesterday. They were frustrated because they had been kind of trying to do it themselves, and they were seeing the variance in the versions that they weren't expecting, and then realized, wait, why are we trying to do this on our own? You know, I just want to standardize how I talk to you, and then I'll let Jim and I, you know, and an integration engineer that's has special knowledge handle those variances. The whole need, you know, modern tech vendors, you know, they're building their applications in JSON, and that's where their expertise is. And it can just be hard when you're doing a lot of point-to-point interfaces to scale versus, for example, having something that falls under this umbrella of nationwide data exchange. And Mike made a point that even if the versions are the same, the implementations deviate. You're exactly right. Somewhere along the way, someone just decided to put it in field 3 instead of 4, as Michael said. Now you're counting pipes, or they're using Z segments in creative ways, and Z segments are fun because you can do creative things with them, but they can also drive you crazy because it's like, wait, what is here? So yeah, having expertise certainly helps.
Yeah, I mean, you look at it like I look at it like flavors of vanilla. I use this a lot. It's flavors of vanilla, right? Is somebody say I want vanilla ice cream. I want HL7v2. Well, there's French vanilla and vanilla bean and triple vanilla, and is that regular ice cream? Is that soft serve? Like they're even inside the what you think is a very generic term of vanilla ice cream, you still have lots of variations, and to that point is, you know, V2 is supposed to be backward compatible. So if you're dealing with 231, you know, 2.6 should work with 231. But to your point of field variances or folks that have plugged in Z segments, and you plug in Z segments at the source, and then you have to deal with them to all your downstreams unless you have multiple copies of your ADT or your other interface. So those are the sorts of things of you know what you kind of see as some of the challenges.
Yeah, definitely. And you know, quite honestly, we run into similar problems with FHIR, different versions and even different implementations of FHIR, smart on FHIR, there's bulk FHIR. So, you know, some of these problems are consistent with, you know, data standards generally. So a couple of ways to overcome some of these challenges, certainly, you know, using a hub approach where you can take if you're a provider group, and again, talking to one right now as we speak, that, you know, has eClinical works and is paying a license fee every time they have to do a new integration, and they're a very innovative group, so they do have to do that a lot. So this concept of having one data feed type that's connected to a hub like Gemini, and then being able to repurpose that same interface type across multiple integrations with third parties where we can handle the filtering and the routing. And obviously there's other systems that do that, that really can help improve that, you know, using tools like our JSON to HL7 service that even automates this transformation between those JSON and HL7 to make that last mile mapping, you know, even more focused and easier. And then looking for other ways of handling the security with HL7v2. So you can use HTTPS or certificate-based exchange, and that we have talked with HIEs about hanging an HL7v2 message around an IHE message, with the IHE message and the certificate-based exchange kind of handling the transport layer. Basically just more, and there are certainly others that where we can still have an HL7v2 message as a payload, but we're not necessarily forced to do a VPN message. And Michael, I think you
forgot my near real-time VPN. I mean, SFTP model. You didn't include that.
Thank you.
Yes, we you know, if you want fake real time, then you just pull an FTP directory or SFTP directory, and you dump HL7 messages in it, and then you come get them every 5 minutes, and then you have near real time with no VPN. But not all of us want to do that. But you know,
not all want to do that. Zen has certainly done our share of that use case for sure. And then, and Michael, I think you said that this whole VPN problem, you know, in your mind, you're kind of thinking about can you create a guide so that maybe other hospitals can be thinking outside the VPN box for HL7?
Yeah. You know, that it's a good point. I think that, you know, part of the rub here is when you, and again, a lot of my experience in the last 20 years has been working with Epic. And when you think about V2 ADT, you think about bridges and you think about site-to-site VPNs and really interconnect, which is their API, outwardly facing API tool, can handle HTTPS. So creating a playbook that gets people comfortable with the idea that you can actually send and receive ADT data via HTTPS and creating that playbook and getting people comfortable with that idea is something that I think is a worthwhile effort and moving that forward because when you get into a healthcare system and you're setting up a site-to-site VPN, you need network engineers, you see security engineers, and then if something were to change, you're gonna need to redo that or refactor that or move something. You change data centers, whatever. Whereas for that HTTPS piece, you're connecting in again in the Epic world into interconnect. It's a pretty straightforward process. So that's something that I'm looking at for sure.
Have
Trying
any
to
of
push
our
that along.
Yes. Well, yes, we would love that. The playbook, we're super excited about the playbook. If you write it, we'll help you get it out there in the world. So any of our HIE friends have any experience with or anyone else on the call with getting folks to do HL7v2 but using HTTPS or other security models?
I mean, we use it through Zen. Zen has their HTTPS with mutually authenticated TLS. We use that when we can. You just have to update the certificates on the periodically instead of leaving the VPN up for years at a time.
Yeah, exactly. Well, we're hopeful that maybe based on the fact that we think HL7v2 is going to be around a while, that this HTTPS idea gets some legs underneath it for sure. And then I think the other one that will be very interesting is, can we start to create push model from a national network perspective. So leverage the common data sharing agreement, leverage the ability to publish an implementation guide or create an SOP and TUFCA-based exchange and create some use cases for push. I know Commonwealth has played around with some counter notifications use cases. I don't think they've been widely adopted, but we're starting to see some experimentation there. And if anyone on the call has any sort of insight around maybe some conversations happening at the QHIN or network level, please put your hand up there. And and Mike asked if we do OAuth, and yes, Zen definitely supports JWT, OAuth, both token as well as certificate-based exchange. So anything that we can do that isn't a VPN, we want to do.
And really just, if you want to go through the laundry list of things that you think technology would have gotten rid of, if you want to use the interop example, you would think that nobody would be sending data using a fax machine, but still exists, and it probably will exist. That will probably continue to happen. So, I think there's probably some TVs out in the world that have the old, rabbit ear antennas connected to it. So even though there are different standards, some of the existing standards and technology that works continue to work. Again, unless somebody unplugs it or stops it from working. So, V2 for the foreseeable and near-term future, actually, even in California, there's something called the Data Exchange Framework or DXF that actually published the regulation that said you had to do bit notifications using ADT. So they actually wrote that into the reg. So I don't know that I think we're safe with leveraging V2 at least for the next 5 to 10 years. If FHIR comes and replaces or if comes up with something better, I still don't think it goes away that quickly. So
I'm so glad you brought up California because they have certainly been very active in building out use cases as part of that DFT. So yeah, that's a really good call out. All right. Well, I don't see any other comments in the chat. I do want to highlight the fact that Jim, I'm going to put you on the spot. What is the date of your interoperability workshop?
I don't have it laid out yet.
Oh, okay.
So it's coming up
So
in,
there is no date, but coming soon.
yeah, coming soon, 2.5, 3 weeks, something like that.
Okay,
Yeah,
awesome.
Jim's going to go through the different variants of ice cream that can be analogies for HL7 and interoperability. So I
I'm
stole
gonna-
vanilla. You've got to come up with your own ice cream, Jim, even though I appreciate the
I even said in the chat, I'm stealing it, bud.
yeah, no,
I love
yeah,
it.
steal away. I think that one of the things is that, as much as things change, there's also some consistency and things stay the same. You run into the same problems. We just kind of find different or maybe better solutions. And I think, in the interop space, we're going to continue to run, we need to get data from point A to point B. We need to eliminate administrative burden. We need to maintain data quality. And I think all the tools and things we use. Thank you for posting them, Mike. I'm assuming this Chems is an Oregon ice cream or something. It's not a flavor I'm familiar with.
I'm not
But,
familiar with it either. It just popped
okay.
up when I was
The,
searching for
inter-
types
the
of vanilla.
internet, yeah, the internet wins. The speed of the internet wins on that one. But
Oh, God,
anyway,
that's great.
Yeah, absolutely. And one of my next office hours is April 30th at 1 p.m. last Thursday of the month, like my normal routine. I don't have the topic finalized, but I'm kind of leaning towards moving to a discussion around fire and this whole concept of all the different fire related projects that are happening, because I am sensing a big acceleration in the use cases. And I think it's important for us all to kind of keep up with all the possibilities.
well, Marilee, you just said it. Is everybody familiar with all the fire accelerators?
Yeah.
So there's the
Right.
Fire at Scale Task Force, there's Da Vinci, there's Vulcan, there's a ton of them. So there's actually HL7 work groups in place today. So if you're interested in fire adoption and fire use cases, check out the HL7 Confluence pages and sign up for those. I think there's 8 to 10, maybe 12 use cases out there that are actually looking for volunteers to help drive that fire adoption. So those fire accelerators, as you just said, lots of different work groups. I've done a lot of work with the Fire at Scale Task Force. That was way too technical for me, so I moved over and spent more time with Da Vinci, which is the payer provider interoperability playbook. So the 0057, which is electronic prior auth use case. It's supposed to be in place by January of next year. I got a lot of experience there, but again, would encourage people to engage and better understand what's happening out there, because it's a emerging and evolving standard, and your voice is needed and helpful in those work groups getting that work done. So
Excellent.
Absolutely. And I think, and particularly where we've had stakeholders like payers that maybe have kind of just been over there in the past doing their own thing with X12, all of a sudden, we're bringing them into the data exchange world, and they're kind of skipping some of the legacy stuff that besides the X12 world and moving right to FHIR. And a lot of their use cases, FHIR actually works pretty well for that. So yeah, excellent point. Well, I really want to say thank you to everyone for being on the call today and joining us in this lively discussion. As always, appreciate everyone who participated and also came and listened in. And we look forward to seeing you at the next office hours.
Yep.
Thank you, Michael.
Thanks, Marilee. Appreciate the invite. We'll talk to y'all later.
Thank
Thank you.
you.
Bye.
Bye.